Thank you. I can't promise to be as good as Anna, but I'll give it my best shot. So it was a brilliant day so far, and I don't know about you, but I'm having a ball. I've been away from the hospital for a few hours, so I'm enjoying every minute of it. So, well, it'll be a while before I join you there, John, but I'll get there. So, unlike Anna now, I've done a little bit of homework on the name pronunciation. So I'm delighted to welcome our first speaker, Dr. Jieun Oh. Jieun, I asked Jieun earlier, how do you pronounce her name? And she said, June, July, it's easy. So, so there we go. So Jieun is an SHO in Galway. And she's special interest in minor and minimum invasive surgery, non-invasive procedures, and chronic disease and inflammatory bowel disease, okay? So we're looking forward to hearing you, Jieun. So come on down.
Good afternoon. Good afternoon. My name is Jieun. I'm a senior health officer at Galway University Hospital. I'm a young doctor, fresh researcher, so I'm so honored to present this case in front of all these talented researchers with many years of experience. Many thanks to Christina, who's a future general surgeon, and Abdul, he's a dentist, and I would like to become a gastroenterologist. So from all our interest, we decide to come up with this research idea, oral microbiome. It can be effective screening tool of colorectal cancer. So all of us met in George Washington University in United States research conference. So we're thinking, oral microbiome has been involved in pathogenesis of gastrointestinal cancer, especially colorectal cancer, and is most of the world's deadliest cancer in the world. And by the end of 2030, we're expecting 2 million new cases and 1 million death cases of colorectal cancer. But with proper screening, colorectal cancer can be most preventable cancer. As of today, there are stool-based tests and direct visualization tests and serology tests for screening colorectal cancer. There are still few research about it, but it has some limitation that sample was too small, so they can't confirm sensitivity and specificity for oral microbiome detecting colorectal cancer. So our objective is we'll study. It can be oral microbiome can be cost-effective, easily accessible, and less invasive annual screening tool for colorectal cancer compared to colonoscopy. And we set our primary hypothesis as profiling the oral microbiome will have sensitivity and specificity comparable to colonoscopy, which is gold standard. And secondary hypothesis, we will be able to differentiate non-cancerous and cancerous polyps by profiling oral microbiome. Our inclusion criteria will be men and women who's aged more than 40, who have undergone colonoscopy as a screening method. And our exclusion criteria is obviously who has IBD, IBS, colorectal cancer, and who has previous malignancies in the last 2 years. So this is simulated data of ours. And from our data, we will divide into group colorectal cancer positive, cancer positive, and non-cancerous polyp, and polyp negative. And we will divide those data into sex, age, BMI, smoking status, alcohol status, and exercise status. This is overview of our research method. So we'll do colonoscopy and divide those groups into polyp positive and colorectal cancer positive and polyp negative, and we'll do oral swab test and fecal test. And fecal sample will be self-collected, and oral sample will be rubbing from the mouth, both cheeks. And obviously, they have to rinse before, and it will be morning will be best case, best timing to do oral swab test. And then after that, we will do gene amplification sequencing. And we'll find out Streptococcus, Haemophilus, Prevotella, Fusobacterium, and Porphyromonas from oral swab test, and Fusobacterium and Porphyromonas from fecal test. And we'll do ROC to determine the accuracy of oral microbiome test against gold standard, which is colonoscopy. So this is the result we'll see. The real black line is fecal test. Oral test. And the dot line is the stool fecal test. And we can see there are high sensitivity for oral swab test, which is comparable for colonoscopy, and which can increase true positive cases comparable to fecal test also. From precancerous polyp, there are relative abundance of Streptococcus and Porphyromonas, and less abundance in Prevotella. So from this result, we can kind of predict this patient will most likely to have colorectal cancer or not. There are still some limitation and challenge in our study. Study is expected to determine that profiling the bacteria associated with oral cavity may serve as an effective screening tool for early detection of colorectal cancer. And with combining fecal test and oral test will increase the sensitivity. And we're supposed to show comparable result for oral swab tests compared to colonoscopy, which is the gold standard. So that's our another challenge. So sensitivity have to be more than 98% for colorectal cancer and 92% for colorectal polyp. Our tertiary endpoint is accessing other lifestyle factors can help determine confounding variables. And we should identify cutoff values in the test of oral microbiome between cancerous and precancerous polyp. That's one of our challenges also. In the case if we do not observe the expected result, we can consider possibility that oral microbiome can change prior to development of colorectal cancer. So in this area, there are more research needed. Another limitation is that our results are dependent on screening results through colonoscopy. So we're kind of dependent on colonoscopy results as if colonoscopy has 100% sensitivity and specificity. Role of oral microbiome in the pathogenesis of colorectal cancer is still unclear. But with more research on this topic, we can use oral microbiome as a therapy. And also therapy, and also screening tools. So there's both benefits of it. There are lots of complications of colonoscopy, like perforation, bleeding, and dehydration, nausea, vomiting, and cardiovascular respiratory effect. So we usually go to colonoscopy every 2 years after age 40 or 50. And we don't want to take this risk. So if there's any probable outcome of this oral microbiome, it will be actually great in the future for colorectal cancer. And this implies that there will be more higher percentage of participation. And in our healthcare system, this is the most important thing, the price. Yeah. Oral microbiome costs only $10, including DNA sequencing tool and profile oral microbiome. Yeah. Yeah, these are the references. That's all about it. Thank you.
Thank you so much, Dr. Jieun. I can certainly think of lots of advantages to not having a colonoscopy, so it's very interesting. Does anybody have any questions?
Can I ask you, why did you, just get the guys on the line? Why did you exclude, for example, IBD and Crohn's when you were doing this? Because I imagine they are people you might want to find out whether or not they've got some, cancerous disease going on.
That's true, but we want to have a proper outcome of this study. IBD and IBS, those patients, especially IBD, who has ulcerative colitis, they're more likely to have colorectal cancer, so our study can be biased. Yeah. But obviously, if we found out that oral microbiome can be early screening tool for colorectal cancer, it will be really helpful for IBD patient to predict their cancer, colorectal cancer in the future.
Anybody else have a question? Okay.
Does the patient's dietary choices have any changes that you could see in this? So if they were a vegetarian or a vegan, would that affect
Or
what
a
you're
micro.
seeing?
So our study is based on predicting colorectal cancer, and their diet, it really makes changes. So we'll have to find out, we have to track, because all different ethnicity have different diet habit. So we'll also have to find out, so there's a background and research saying that Mediterranean diet actually helps for colorectal cancer. So that's good factor also.
No, that's great. Thank you very much, Dr. Jieun.